Welcome to AJP Audio for November 2024. I'm Aaron Van Dorn. Today on the podcast, I spoke with Dr. Phuc Lee, an assistant professor at the Cleveland Clinic, Case Western Reserve University. Dr. Lee and colleagues have a paper in the November issue of AJP looking at the disparities in treatment for people with alcohol use disorder in a large cohort. Following that, we will once again speak with Dr. Ned Kalin, Editor-in-Chief of the American Journal of Psychiatry, about the rest of the November issue of AJP, which focuses closely on issues surrounding substance use disorders. Dr. Lee, your study looked at racial, ethnic, and socioeconomic disparities in treatment for people with alcohol use disorders. What did you find?
So we found some differences in how alcohol use disorder, or AUD, is treated across racial, ethnic, and socioeconomic groups in the U.S. For example, non-Hispanic Black and Hispanic individuals were less likely than non-Hispanic white individuals to receive FDA-approved medications, while there was no difference across racial and ethnic groups in terms of receiving psychotherapy or combination therapy. There were also differences across insurance types. So compared to people with private insurance, now those with dual eligibility or those with Medicare or Medicaid alone were also less likely to receive medications. Whereas those with VA insurance were more likely to receive psychotherapy and combination therapy. So in our study, combination treatment was defined as receiving both medications and psychotherapy. And the other finding is that overall, people with higher incomes and those living in a less deprived neighborhoods were more likely to receive any kind of treatment.
Your study found that Black and Hispanic individuals were less likely to receive medication treatment for AUD, but there was no statistically significant difference between the rates of psychotherapy treatment and combination therapies between the groups. You also found differences between the types of insurance cohorts. What can your findings tell us about how alcohol use disorders are diagnosed and treated in the United States?
Great. So our study focused on how AUD is treated among those who were diagnosed. And our findings suggest that the way that AUD is treated in the US can favor certain groups. So, as I said earlier, we found that Black and Hispanic individuals was less likely to receive medications than non-Hispanic white individuals. And I think this could be due to several factors like limited access to information, lack of insurance, limited access to treatment facilities. There are also differences in how treatment is recommended and provided across racial and ethnic groups. Interestingly, there wasn't a big difference in access to psychotherapy across groups, which suggests that talk therapies might be more accessible or accepted in different communities. In our study, insurance seems to also play a huge role. People with private insurance had better access to medications, whereas those with dual eligibility or Medicare or Medicaid alone often had less access. However, those with VA insurance were more likely to receive psychotherapy and combination therapy. And this shows that how insurance policies and coverage types can shape the kind of care that people receive. And these findings of emphasize the need for more inclusive interventions so that everyone has equal access to effective treatments for AUD.
Your study found that the Veterans Affairs system generally outperforms other forms of insurance in alcohol use disorder treatment provision, despite perhaps working with a cohort who might be at higher risk of other mental health factors and homelessness. What are they doing that other providers can learn from?
So first, I must acknowledge that I do not study the VA health system well enough to answer about their specific practices in treating AUD or substance use disorder. However, I think that the fact that they offers a better access to treatment for AUD than many other insurance type was impressive because, as you said, VA patients often face higher risk of coexisting mental health challenges, polysubstance use disorder, and even homelessness. So, one key difference, I think, is that the VA is designed as an integrated healthcare system, meaning that it provides a full range of services, including mental health, substance use disorder, and social support, and all under one umbrella. And so this setup, I think, makes it easier for patients to get connected to the right services without as many barriers as in other systems. I think the VA also have invested heavily in mental health resources, and they have specific programs that target issues like substance use and PTSD, and that This approach not only makes care more accessible, but also creates a supportive environment where patients are encouraged to seek help. Learning from the VA, I think other providers could prioritize integrated care models and focus on reducing stigma and barriers around substance use treatment.
Your study drew from the All of Us cohort. What can you tell us about the demographics of the population you were looking at?
This is a new kind of data set that is available for researcher in the US. And the All of Us cohort is a diverse population which was designed to represent various backgrounds across the US. For the cohort itself, like we do have participants from like all 50 states, with 84% self-identify as members of communities underrepresented in biomedical research, and 43% self-identify as members of racial and ethnic minority groups. For our specific analysis, we look at like 18,692 adults with AUD, and the average age of this study participants was 57. We have 61% were male. In terms of race and ethnicity, only 47% were non-Hispanics, white, and the rest was like other minorities groups. So I think this diversity is important because it allows us to examine how racial and ethnic groups experience treatment for IUD in the US, as well as how socioeconomic factors come into play.
Are there immediate clinical implications for your study, especially for clinicians working with at-risk populations and people already diagnosed with AUDs?
Yes, our study has several clinical implications. So one key takeaway is that we, we need to increase awareness about these disparities in treatment access. So clinicians should be mindful that non-Hispanic, Black, and Hispanic patients, as well as those from lower socioeconomic backgrounds, may face barriers to receiving medications. And so this could prompt healthcare providers to proactively discuss treatment options and advocate for the patient's access to medication. Another thing is that given that many individuals with AUD are not receiving treatments, so in our study was 70%, it's very important for clinicians to routinely screen for AUD and engage patients in conversations about drinking habits and treatment options. It's also important for providers to collaborate with social services to address the broader social determinants of health that can impact treatment access, for example, like income and insurance status. And finally, our studies emphasize the importance of integrating different treatment modalities. So clinicians should consider a more comprehensive approach that includes not just medications, but also psychotherapy and other supporting services, especially for patients who may benefit from a combination treatment.
What were the limitations of your study?
Our study had several important limitations. And first, the All of Us database contained missing electronic health record data, which can affect reliability. We also don't have complete information on treatments that receive outside of the healthcare system because this analysis was based on electronic health record data. Whereas patients with IUD, very often they seek like non-traditional care. Data quality can vary across providers, which will impact how accurately information is recorded. Our findings may not apply to individuals who don't engage with the healthcare system or those with polysubstance use disorders. We also relied on self-reported survey responses for demographic data, which could introduce recall bias. Our data set also didn't capture details about the 12-step programs or other factors influencing treatment decisions, for example, personal beliefs or social and community support. Finally, while the All of Us program emphasizes minority representations, the database doesn't fully represent the broader US adult population, so it might limit the generalizability of our study findings somewhat.
What's next for your research?
As for the next step, one important area is to understand the effectiveness of different treatments on long-term health outcomes in the real-world settings, which we are actively pursuing. We also receive federal fundings to estimate like the long-term health outcomes associated with AUD. And so we are trying to build a decision models that will capture different health impacts of various drinking limits, like drinking levels, and we will use that to estimate the benefit, like the comparative effectiveness of different treatments, including medication, psychotherapy, and combinations of the two. And finally, we hope that we can use that information to incorporate it into a decision aid and see if that incorporations will improve people receiving treatment or clinicians increase in recommendations for treatment.
Dr. Lee, thank you for taking the time to speak with us today.
Thank you so much for the opportunity to share about our research.
Up next, Dr. Ned Kalin. Dr. Kalin, welcome back to AJP Audio for November 2024.
Thank you, Aaron. It's a pleasure to be here.
The November issue of AJP takes a close look at substance use disorders, and our featured article by Dr. Lei and colleagues looks at disparities in the treatment of alcohol use disorders in a large cohort. What can you tell us about it?
Aaron, this is an interesting study with some important findings that have important implications. We've known for a long time that a small percent of the population that suffers from substance use disorders gets treatment. In this particular case, there's, I think, two takeaway points in this particular paper. This is focused on alcohol use disorder. One important point is that many people with alcohol use disorder that are studied in this study do not receive treatment. And that lack of receiving treatment is magnified and worse in individuals of color. More specifically, this is a study that used the All of Us sample, which is a sample that is currently being developed by NIH and others to try to accumulate 1 million individuals with a lot of biological and other data to better understand a variety of illnesses that our population suffers from. So from this data set, roughly 19,000 participants over 18 years of age were identified that met the criteria for an alcohol use disorder. And as I mentioned, one of the questions in this study was to look at diversity and how diverse individuals receive treatment. This population in this study, roughly 53% of the participants were non-white. So this is a quite diverse sample. As I already mentioned, not a lot of these individuals received treatment. The remaining 30% that did get treatment, 11% of these individuals received medications, 24% got psychotherapy, and only 5% were treated with both modalities. And as predicted, there were racial and ethnic disparities in treatment. And this was particularly apparent in relation to medication treatment. Black individuals compared to non-Hispanic white individuals were receiving less treatment, and the odds ratio was about 0.78. So that suggests that, over time, individuals of color were much less likely to receive treatment than white individuals. So I think it highlights, as I mentioned already, the importance of trying to enhance access to treatment, the importance of really trying to focus on minority populations and marginalized individuals and individuals of color to try to get them treatment. And also, as you know, this is a huge problem. Roughly 30 million individuals in the United States were estimated to suffer from alcohol use disorder in 2022, just to give you an example of that.
The November issue also has a clinician-focused review from Imperio and colleagues looking at the neurocircuitry of substance use disorders.
So this review is interesting. It's very comprehensive. It looks at all the different substance use disorders. It talks about some of the neural circuitry that's been implicated across these disorders, as well as some of the specific types of alterations that may be associated with individual disorders, although there's a lot of similarity when we think about neural circuit alterations. And importantly, discusses the different medications that are approved and those that are not for the treatment of these disorders, and how these medications may actually impact the neural circuitry that's involved. So overall, a really good review, I think, for clinicians to review the different substance use disorders, to get a bit of a sense of the neural circuit involvement, neural circuit alterations that are involved, and also to review the medicines that are approved for these disorders and how they may affect the brain of individuals that are suffering from these disorders.
Next, we have an article from McClure and colleagues that takes a look at the impact of reduction in cannabis use on functional outcomes.
So this is a study that focuses on what we call harm reduction strategies. Traditionally, treatments aimed at substance use in individuals that suffer from substance use has been to achieve abstinence, which of course is the goal that we want to achieve. But from a reality standpoint, many individuals don't achieve full abstinence or they don't stay abstinent forever, but rather they reduce their actual consumption or use of substances that can hurt them. And, so focusing on this and actually making this a target of treatment is a bit of a different strategy than just going for abstinence. And this particular paper really demonstrates the value of harm reduction strategies, that is, focusing on reduction in use and perhaps not necessarily abstinence. This is a study that was done in 920 individuals that met criteria for cannabis substance use. And all these individuals had been enrolled in a variety of different treatment studies. And the authors really sought to understand the extent to which reductions in cannabis use were associated with positive outcomes, even if individuals didn't become abstinent. And they were particularly interested in functional outcomes because ultimately functional outcomes are what best are associated with success in the world. And what they found is not all that surprising, but again, important to characterize and scientifically document. And that is that there was an association between the amount of reduction in cannabis and positive outcomes. One of the major outcomes that they used, which was a primary outcome measure, is a scale called the Marijuana Problem Scale. But there are also robust reductions in a variety of other scales, including the Global Impression Scale and the scales related to functional impairment. We have a really nice editorial on this paper from the NIDA, the NIDA group, Wilson Compton and Nora Volkow, who is the director of the National Institute of Drug Abuse, that not only review the findings, but make the suggestion that the data that's presented in this paper support the FDA to think about resetting the criteria for the approval of medicines aimed at folks that are struggling with substance abuse. And that is to say that the criteria doesn't necessarily have to be full abstinence, but rather significant reductions in intake, which are associated with significant positive functional outcomes for these individuals.
Next, we have an imaging study from Perlman and colleagues looking at the association of neuromelanin-sensitive MRI signals with lifetime substance use in young women.
So this study begins to try to get at the underlying changes in the brain that may be associated with substance use disorders, and more particularly tries to better use imaging methods to understand alterations in the dopamine system. Now, we've known for years from animal studies, human studies, that dopamine systems are altered in individuals with the struggle with substance use problems. We also, know from all kinds of studies unequivocally that dopamine is very important in reward, reinforcement, positive feelings, and so on, and addictions. This particular study used a relatively novel new imaging technique called neuromelanin imaging. And we've actually talked about this before. We've had some earlier papers where this type of imaging has been used in individuals with schizophrenia and actually even with cocaine use disorders. Neuromelanin is a product of dopamine that gets deposited in the cells and can be detected with MRI if you use the right parameters. And so it's really a proxy for dopamine in specific cells. But what's really interesting about neuromelanin is that it accumulates over time in individual cells. And so it can be a marker, perhaps, of long-term exposure or use of medications as they may affect dopamine systems. Now, the dopamine systems in the brainstem, specifically the substantia nigra and the ventral tegmental area, are where the cells originate that have dopamine in them that project throughout the brain that have to do with reward reinforcement and addictive processes. And so they specifically looked at the brainstem in these regions and asked the question, was there a relation between the levels detected with MRI of neuromelanin and one's history of substance use over their lifetime? Now, the sample that they used is important to keep in mind. It was a sample that was not recruited based on substance use. It was basically sort of a community sample of adults, roughly 135, or exactly 135 individuals, 105 women and 30 men were recruited into this study. And the lifetime history of substance use was assessed in these individuals, and then they underwent this neuromelanin imaging. And what they found was that, in fact, there was a positive association between the amount of neuromelanin that was detected by this imaging method in the brainstem, in these critical dopamine regions, with an individual's history of cumulative substance use. Interestingly and importantly, this finding was only seen in women. It It was really accounted for in women. So there may be a sex difference, although keep in mind that the proportion of women to men in the study was quite different. As I mentioned earlier, there's 105 women and only 30 men. So it may be that there weren't enough men to really detect a signal. So I wouldn't get too excited about that finding. But needless to say, this is demonstrating a couple of important things. One is more and more evidence suggesting that we can use neuromelanin imaging to study the pathophysiology of psychiatric disorders that involve dopamine, in this case, substance use. And also that it appears that this marker may be a marker of long-term use and the amount of use in individuals, which could be important. So I think it's an early study, but again, it's quite interesting and begins to get at the pathophysiology of substance use disorders.
Another paper by Savage and colleagues takes a look at alcohol use behaviors, this time from a genetic perspective.
Another really interesting study in relation to substance use, now focusing on alcohol use disorders. This is a study that tries to further help us understand the underlying genetics of alcohol use disorders. We know a lot about the genetics. There have been many twin studies demonstrating that substance use and alcohol use are heritable to some extent. There have been a number of GWAS studies on a large scale that begins to identify specific structural variation in genes that may contribute to the likelihood of someone to overuse alcohol in a way that is pathological for them. But what this study does is it tries to go beyond simply substance use disorders, but ask questions about the specific behaviors that are associated with substance use disorders. Now, why is that important? It's important because, not everybody is the same. Each individual that might meet criteria for substance use disorders may have different components, different symptoms, different behaviors associated with overuse of alcohol. And the authors contend that by understanding the genetics of these different behaviors, that may give more insight into the heterogeneity that we see across individuals that suffer from these problems. So they identified a number of behaviors that were associated with alcohol use. This was using the UK Biobank data, which has been used for many studies. In these individuals, they looked at 18 different behaviors.
Mm-hmm.
And what they found is that there was a lot of genetic components that were shared across these 18 behaviors. But one genetic alteration was shared in common across all these behaviors. And that was genetic variation for an enzyme that is related to the metabolism of alcohol. So this begins to say that we can understand the genetics of these different behaviors. And then what they did is they went on to do what we call a latent factor analysis, which is a statistical method to take these 18 behaviors and to see how they best group as far as groupings, how their ones are related to the other and how they're best differentiated. It's a way to sort of sort through and categorize different behaviors into different types. They came up with 4 what they call latent factors. One was for problem behaviors associated with alcohol use. Another was for individuals that had a preference for beer, and also they were drinking outside of meals. Another one was for consumption of what they called atypical or uncommon types of alcohol. So then what they found, they asked what are the genes that are associated with these different 4 subtypes, and they found that there were different genes that were associated with these different subtypes, and there were some shared as well. And they also found, interestingly enough, that the 2 subtypes, the problems subtype having problem behaviors, and also the preference for beer, were more strongly associated with the later or the diagnoses of actual alcohol substance use disorder. A bit of a complicated study, but the bottom line is that it gets at the genes that are involved with the behaviors that are associated with alcohol use disorder. It then groups these different behaviors into sort of different subtypes and then gets at the genes that are associated with these different subtypes, suggesting that we can now begin to think of subtyping the phenotypes of individuals with alcohol use disorder into these heterogeneous groups, and that there may be different genes that are shared as well as distinct that underlie the liability to have these different subtypes.
Finally, we have a priority data letter from Phuc and colleagues looking at distinctions between the prevalence of use disorder classification between DSM-4 and DSM-5. What can you tell us about it?
So this is sort of a conceptually simple study, again, with interesting implications. It basically looks at the same individuals who have substance use disorders and then asks the question, if you use DSM-4 criteria, do you get the same or a different number than if you use DSM-5 or current criteria? Now, why did our researchers do this, or the researchers that were involved do this? They did this because we're now using DSM-5 and they wanted to see how the changes in some of the criteria actually impacted the prevalence or the diagnosis of these disorders. And what they found was, and again, the bottom line is that when using DSM-5, there's a significantly greater number of diagnoses made than when using DSM-4. Well, why is this? Well, first, let me describe the data that was used. It came from the 2021 National Survey on Drug Use and Health. It included 18 to 64-year-olds that were using alcohol, cannabis, cocaine, or inappropriately consumed prescription opioids. Now, some of the changes that were made between DSM-4 and DSM-5, and one of the major ones was not separating the abuse and dependence diagnoses, which were separate in DSM-4. They were put together in DSM-5. And also in DSM-5, in relation to cannabis use disorder, there were withdrawal criteria that were added. And across all of these disorders, craving was also included as a criterion. So those were the changes. And the findings revealed, as I mentioned, higher levels of diagnoses with DSM-5. And, just as an example, when thinking about alcohol use disorder, the use of DSM-5 criteria resulted in 18.7% of this sample showing that they had a diagnosis over the preceding 12 months, whereas it was about half that, around 9.9%, when using DSM-4 criteria. This shows us how changing our criteria can make a difference in how we make diagnoses. Obviously, the folks that made these changes felt that they were more accurate, and it's really important to see that this is actually detecting significantly more individuals. And the reason I think that this is important and validating is because hopefully this will point to more individuals earmarked for treatment. Although, as I said earlier, it's, in this other paper that we talked about, and again, in relation to alcohol use disorder, only 30% of the individuals that were studied in that sample, the other study, received treatment. So it's woefully low, but this is identifying more individuals that probably would benefit from treatment.
Well, Dr. Kalin, thank you once again for joining us.
You're welcome. Thank you, Aaron.
That's all for this month's AJP Audio, but I hope you'll check out the rest of the APA's podcast at psychiatryonline.org or wherever you get podcasts.
The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent those of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.